So this morning we're going to have a chat with you about practical information and appropriate management of problems related to diet, nutrition, eating and swallowing. So can you tell us a little bit this morning about the role of the dietitian in MND care?
Certainly. The role of the dietitian in MND is certainly not to give healthy eating advice. So the main role of the dietitian is really to work with the patients to optimise dietary intake and to prevent weight loss and hopefully maintain weight loss over the course of their disease. I work very closely with the other members of the MND team, and in particular with speech pathology. And depending on the degree of dysphagia, we'll adapt that information, that dietary information, to help patients and their carers to prepare food to meet their nutritional requirements. So that might be extremely difficult given the degree of the stage of their MND. It may be difficult in terms of the various symptoms they have and their ability, even just physical ability, to feed themselves and prepare food. So a large part of the role is actually working with the patients and the carers to help them modify their diet to meet their nutritional requirements. And that might be just through fortifying food. It might be through the use of specialised nutritional products. It might be through the use of gastrostomy feeding. But the main thing, I think, is that MND is obviously a progressive disease, and it's really important in terms of referral that the referral is placed early so that we can monitor these changes and keep on top of fluid and hydration right from the beginning, so that we can help maintain weight and nutritional intake.
That's a really good reminder about early referral and getting on top of things early and keeping that top of mind. So can you tell us a little bit about the common impact nutrition symptoms might have or people with MND might experience? Are they important, and what strategies can be employed to manage them?
So the most common symptom that we see presenting to our clinic is weight loss.
Okay.
And it's not uncommon for patients to present with 20 to 30% loss of body weight. And we know from the research that up to 50% of patients in the literature have severe weight loss. And this is really important from a clinical perspective, because we know that poor nutritional status has an effect on survival, it has an effect on the development of motor symptoms, of worsening of motor symptoms, and quality of life. So we can actually improve these things by maintaining weight, and it has a very positive effect, whereas deterioration of nutritional status has a negative effect. So again, that would sort of reiterate the fact that early referral to the dietitian is really important. On top of the weight loss that we see, very frequently patients present with no appetite or very little appetite. And again, recently from the research, there's been a lot of attention paid to these changes in appetite in the motor neuron disease population. And therefore, we know that patients really struggle to eat, and we know that they really have difficulty meeting nutritional requirements. So there are many changes in in appetite and eating behaviours, and we know that there are a number of reasons for this in motor neuron disease. And one of the many reasons is that some patients have a hypermetabolic response. On top of that, there may be anxiety issues with stress. We know that a number of patients have frontotemporal dementia, and these can all impact on appetite. On top of that, we also have issues with patients being unable to feed themselves, physical disabilities, and this can really impact on how much energy and protein and fluids that the patients have. We also know that 25 to 35% of patients develop at onset some degree of dysphagia, and by the time the disease progresses, this can be up to 80%. So all of these factors taken together make it extremely difficult for patients with motor neuron disease to meet their requirements.
So Liz, if a person living with motor neuron disease is suffering from these symptoms that we've just talked about, how can we deal with that? What are the treatments or the therapies available to deal? And is there another way of getting my calories?
So we mainly work with patients initially with a food-first approach, and we would work with them to fortify the foods that they'd like to have high energy, high protein foods, to make sure they're having the right combination. And we know from research that high energy foods have some effect on survival, and we know that in terms of slowing down the progression of the disease, high energy, high protein diet has a positive effect. In clinic, we would promote high protein powders, and we would use them in smoothies. And again, whey protein has been shown to slow down muscle loss and help delay weight loss. So we would use a combination of high energy, high protein foods. We would also use supplements where if the patient was really struggling to eat the food and just couldn't manage the quantities, we would then refer the patient to have something like Sustagen or Fortisip, something high in energy and protein that's easy to get down.
Right.
And the advantage of referring to the dietitian early is that we can actually get these products much cheaper, and the patient can be included in the home enteral nutrition service. Whereas if they go to their pharmacist, it will cost a lot of money, and they'll have to pick it up, whereas it can be delivered to their home. So there are a number of advantages to the patient to be included into the home enteral nutrition service under dietetic care. The other intervention that we are involved in is longer term nutritional support, and that would take the form of gastrostomy feeding. And we have in Flinders Medical Centre, we would have at any one time 15 to 20 patients receiving gastrostomy feeding. So it is taken up by a majority of our patients. However, again, it's a very difficult decision for patients to take. So we would support them through that decision-making process, and the dietitian's obviously responsible for balancing that nutritional intake between food and what they can have down the tube. If the speech pathologist hasn't made them nil by mouth, we still very much promote enjoying food but topping up with enteral formula to give them their full nutritional requirements. And again, that's got a very positive effect on nutritional intake and hydration, and helps avoid constipation. And there is some evidence to suggest that patients do have extended survival and some improved quality of life because they don't have the stress of worrying about choking. The relatives appreciate that the loved one is having appropriate nutrition and don't have to watch them struggling with long meal times, fatigue, and general deterioration. So gastrostomy feeding does provide an alternative to struggling with food and fluids.
So it's a little complementary kind of
as the disease
strategy.
progresses.
Yes.
Yeah.
So again, that reinforces the need for early referral to the dietitian, so that these things, you were talking about the home enteral feeding program, and that's led by the dietitian, obviously.
Yeah.
So assessment of these symptoms, I guess as a primary care professional, I might see a patient come and notice that maybe that significant weight loss. How can I make a referral? Who do I make a referral to? How easy is it?
Well, it's extremely easy to refer, but I would encourage GPs to go to their local services first. Obviously, if the patient has been referred through the MND clinic, I will see them and assess them and make recommendations to the local dietitian. However, there may be a wait and we have limited services. So in order to get that early referral in, I would encourage GPs to go local first if they're in the country, and obviously if they can put in a referral to the MND state service, then I would pick them up as part of that service. But I think there's a couple of things that GPs can do that's important to perhaps establish early on in the diagnosis, and that is what degree of weight loss has the patient experienced. Very often patients think it's a good thing to lose weight because at some point in their life they've been trying to lose weight, and in fact we know in motor neuron disease that significant weight loss is associated with poorer survival. So we know that those patients are at risk, and the other thing that to look out for is how their appetite's going. So appetite can be affected long before swallow is affected or respiratory dysfunction. So most of our patients do have a problem with appetite, and I think that's a key flag, a key red flag to making sure that there's an early referral to the dietitian.
So you were talking earlier about going local, particularly in country South Australia. So this would mean, or am I correct in suggesting this would mean that the GP would refer to the local dietitian in the local general hospital and then make that referral to the MD clinic, of which you would then oversee it and maybe work in conjunction with the local person?
Yes, so yes. We would liaise very closely with the dietetics in the local area, just as we would liaise very closely with our speech pathology colleagues.
Right.
So it's a really important relationship and a really important reason to have regular reviews of nutritional status and swallow efficiency, because it is a dynamic disease in terms of it can change very quickly. Patients can end up very malnourished, dehydrated, terrible constipation, and
not feel well at all.
So really would make a big difference to quality of life as well.
Which is exactly the objective of this care. So we've talked about eating and drinking and appetite. So, and you mentioned that appetite symptoms come possibly before the swallowing symptoms. So if somebody starts to present with swallowing problems, is this then a trigger to talk to or think about the speech pathologist?
Absolutely. And again, patients' perception of their swallow can be very different to the reality of the situation.
Okay.
But I'll leave that to Megan to discuss as the speech pathologist, as the expert in that area. But I think obviously early referral to the members of the multi-D team, whether they're speech path, dietetics, or OT, it's very important to have that early relationship, because it is a long journey for many patients, shorter for some, but I think obviously we can really help them and support them within that disease process.
That's been really informative. Thank you so much for your time this morning, Liz.
Thank you.